30 minutes. It's okay. I sort of understand, because the two-factor, we have to go through that, and if you don't have that in your phone, they won't let you in. Then she has to be the one spinning the number and saying, what's the number? Ugh. It's not the bank.
Hello, everybody. So sorry for the delay. It wouldn't be 2022 without a little bit of technical difficulties. But we want to welcome you to the 20th Jemsek Specialty Clinic Facebook Live. I'm Rachel Markey. I'm one of the PAs here, and I'm joined by Dr. Jemsek. Today, we are going to be focusing on clinical and social obstacles to initiation and success in therapy of Lyme-Borrelis complex. I'm going to turn it over to Dr. Jemsek first, who's going to explain our mission and definition.
Good afternoon, everyone, and thank you for looking in. This is our 20th episode in 24 months. No, excuse me, our 20th episode in 26 months. And so we think that's quite an accomplishment. When we finish up, it'll be 20 hours of education. And our mission, by the way, is to serve the underserved who have no access to skilled clinical care. And in doing so, we want to provide you with sound advice and understanding of this very complex illness. So that's our mission, because we realize there are untold millions out there suffering in some spectrum, in some place in the spectrum of LBC and chronic illness. And a lot of this is emerging even more so with COVID coming on, because COVID's a massive trigger. But we won't get into long COVID and all the debate about that today. Definition of LBC. If you have LBC, I call it Lyme-Borrelis complex for a reason, because complex covers a multitude of sins. But I don't want to be technical, but to be blunt, you sort of need to hear that it is a chronic inflammatory process fueled by a profile of stealth pathogens, which cause immunosuppression and which invade multi-systemically and which invade the nervous system in a multi-compartmental way. And so immunosuppressive, attacking the nervous system like no other disease in the history of mankind has done in such an efficient and devastating way, the peripheral nervous system as well. So that's the overview definition, which I have published 20 years. In short, there's 3 points, talking points. Chronic and otherwise poorly understood encephalopathy, which is the inflammation of the brain, so that can cause headache, confusion, and obviously mood changes, and so forth. And if that goes on by itself, that's one thing. But number 2 is chronic and poorly understood peripheral nervous disease. So the peripheral nervous system are the nerve roots that exit from our spinal cord. So we're talking about motor weakness, can't lift your hand, can't lift your arm, some twitching, fine twitching, and especially sensory aspects. So all of a sudden you're having a shooting pain, numbness to the hands, particularly the feet perhaps, stabbing pain in the chest, abdominal wall, and so forth that was not there presently, and for which there's no easy explanation. And third, we have a chronic and poorly understood periarticular illness. In other words, inflammation around joints and to include joints. So ligaments, tendons, supporting structures are part of that. Those are the 3 pillars that I put out probably 16 years ago. It's a very simple diagnosis. We have diagnosis printed in journals comprised by different parties, but they're unworkable. They are 3 pages long, single print. It's just, they're not functional, not helpful. Now, if you have 2 of the factors, and then you also have had a bullseye rash, understanding that bullseye rash morphology occurs in only 20 or 30% of folks. Many more get an EM rash without the bullseye configuration. So if you have that, and you have pictures of that, you take 2 of our major criteria, add that minor criteria, and that is a definition. And then another minor criteria that's important is called acrodermatitis chronicus atropicans. So that big mouthful is ACA, and that has to do with lichenification of the palms of the hands and the soles. And that's pretty much pathognomonic for Lyme borreliosis. So there we have our definition. And but if you're talking to someone, and I understand how difficult it is to explain this illness. I have trouble conveying this illness to a skeptical colleague, let's say. You know, I can just imagine all the problems patients have had explaining the illness to their family, to their friends, and to their casual acquaintances, and so forth and so on. I say, what's wrong with you? Well, I have Lyme borreliosis. Well, what's that? You know what? Just tell them it's really complex. I'm infected all the time. I'm inflamed all the time, and my brain is on fire. And just leave it at that. And that's good enough, I think, for right now.
Just leading off of what Dr. Jemsek said as well, just what many of you have said to me over the years of working with you and, you know, dealing with this definition of Lyme. A lot of times you guys say, I get to a certain point where I'm just too tired to answer. It's too complex of an answer, which seems so silly when you're just saying I have Lyme disease, but like, what does that mean? It's like, okay, let me sit down and give you a dictionary worth of information and you probably still won't understand. But what we want to get into is the topic for today and, you know, why we chose this. We are looking at the clinical and social, you know, obstacles to allow for success of treatment of this disease. And there are a lot of outliers that affect a patient's ability to just focus on treatment and their success within that treatment. Dr. Jemsek is going to go over poems first, and then we'll get into some of the outliers and questions you guys asked us about this topic.
So in dealing and learning with a complex illness, and by the way, I've said this before, what we do should be its own medical specialty, because a tick-borne illness, that is, because it cuts across every human system, and it does so in a devastating way. So we wear 10 hats or so here, and we have to be proficient at all of them. It's not that we're expert, and it's not that we don't associate with colleagues and learn from colleagues. That's not the case at all, but oftentimes we teach colleagues. But the point is, I've become a neurologist. I'm probably an average, mediocre neurologist, but I'm a lot better than I was, you know, before I got into this. I have to know about pain. I think I manage pain pretty well without narcotics. I have to know about sleep patterns. I have to know about, you have to be a psychiatrist. And again, don't misunderstand me. If things are in the extreme, we ask for help. The other thing is you have to be humble and willing to learn, because without that, you're pretty useless. If you don't listen to the patient and examine the patient on a regular basis, you're pretty useless. And I like to ask people, I challenge people, I say, hey, what is a doctor without a patient? What is a doctor without a patient? And the answer is nothing. So I feel, especially with chronic illness, this country and the world does a very poor job in dealing with it, because everything has to be expeditious. Everything has to be rush. We only have 15 minutes because insurance has taken over medicine, and they ask you to see 16 patients a day to meet your quota, and all of that nonsense. That doesn't work for a chronic illness. And I think many of you know or have already experienced, if you haven't been here, you understand that people go to 5 doctors, 10 doctors, 15, oh my God, 20. I'm not exaggerating, 25 doctors over the years. And I just so respect the patients that make it here, because they are determined that there's something wrong with them. And having been rejected and the door slammed in their face, you know, a couple dozen times, and they still know that there's something wrong, and they still have a support person. So here's the bottom message here. I hate to say bottom line, because there's a president that says that, and I don't really want to say that after that. But anyway, the moral of the story is that to be a good physician, you have to understand, and I learned this in residency, you have to understand what an untreated illness looks like and what a treated illness looks like. You have to have a sound hypothesis how to treat the patient. You have to have experience in that hypothesis, which verifies that you're making clinical gains. And so when we take our journey with our patients trust us, And we take that trust very seriously, but it may be 6 months into therapy before they see gains. They should see some immediate stabilization, but in terms of gains in treatment, but I tell you what, when you come out the other side, we've had some amazing stories, and we feel so blessed to have helped restore lives. And we get hugs and flowers, sometimes gifts and cards, and we don't ask for those things. Or really, we appreciate them, but the point is that we help change lives, and we do it in a sustained way. So on the other side is, with such a complex illness, it's very important also to know what conditions associated with the illness, and there are many, would preclude starting therapy or preclude success. And we have a list of about 25 I have not published, but nobody else has ever done this. And we work off this and we add to it. And we're going to talk about a handful of them today, just to give you an example of things that can occur with this illness, an incredible array of conditions in all systems that need to be defined. We constantly see things that we could write a case report about, but we don't have the wherewithal and writers and so forth to do that. But one day, this is my fervent hope, is that we will have a research staff here that can really take off, because we could publish 10 to 12 articles a year on short studies, case reports, and then longer reviews. And most of you know we had a GLA study in place 2 years ago, where Jemsek was working with GLA, patient-funded, from patients with Global Lyme Alliance, top-ranked clinical research team, and we're working with 3 universities, University of Missouri, Columbia, New York, and University of California, and San Diego, each doing their esoteric and highly sophisticated bio measurements that can't be done in commercial labs. Anyway, COVID came along and knocked it out, and this was over 2 years ago. It was a pilot study using my treatment program. So that would have rocked the world, because obviously what I'm doing is easily a decade or 2 decades ahead of the curve. Now other people are starting to do what we do and giving a stab at it and starting to understand that we're getting people better. And I admire that, and most of them get it sort of right, but they don't get it totally right. And but good for trying. Just be safe to the patient. The obstacles that we call roadblocks have to be identified. One day we'll publish it. The list is continuing to grow. Some are obvious, and I'm going to point out the most obvious and one of the initial ones that I came up with 20 years ago with the acronym POEMS, POEMS. So POEMS, so pain is a practically universal accompaniment to this illness, all sorts of pain. Complex pain, which is the worst on the planet, neuropathic pain, regional pain, and nociceptive pain, which is large joints, pressure, muscle mass, things of that nature. Each has a different approach. Our patients come to us, and one of our priorities would be to manage the pain without narcotics in a sensible way, using topicals and combination neurotropics usually, and manage the pain so that the patient doesn't feel like they're being tortured. That has to be resolved. O is for others, which is a very broad category, but it can include things like concomitant infections. But the most important factor here, and the one that has to be checked off, is having a support person. If you don't have a support person, whether we treat you with oral or IV, we cannot treat you. You have to have a support person, somebody that knows what's going on with you every day, because this is not child's play. And 3 is endocrine, so all kinds of endocrinologic abnormalities, a couple of which are autoimmune. But the most important one is the adrenal axis, because that's life-threatening if there's a deficiency, and it's not unusual for us to find deficiency. Diabetes insipidus, causing polyuria at night, is another important one because it disrupts sleep. Moving on to M, mood. We have, I've talked to you before about our four-level condo for psychiatric disorder and mood disorder in Lyme. I'm not going to go through that, but on the bottom floor, just to remind you, 100% of people are irritable. So it starts at irritable, And as you can imagine, each floor, there's another flavor and it gets more intense. If it's destabilizing to the patient, then we have to manage that, and we're happy to manage that. And we're happy to work with a cooperative psychiatrist. And we're not afraid of psychosis or hallucinations or depersonalization or derealization. We're not afraid, but it has to be managed. So to the point that the patient is not going to become so unstable that they can't tolerate therapy. So that definitely has to be taken into account. And the last is sleep. Sleep is so important. I can't help anyone who does not sleep. And we understand the phases of sleep. We understand medications that help those phases. We understand RLS, restless leg syndrome. We understand sleep apnea. We understand non-circadian 24 rhythm. And we've seen it all. But so we call it being stabilized. And these are the 5 key areas that we employ. And of course, there are others, but those are the main ones. Okay, I'm going to give you 2, 3 other areas that we've talked about before, but I just want to emphasize the organism Babesia is part of the profile of organisms in this illness. Now, we've identified a half a dozen illnesses and 2 or 3 other pathogens, and 2 or 3 other targets that we need to take care of, and how difficult they are to eradicate, especially when the immune system, as I said, is immune compromised. We have learned that despite good therapy and being very compliant and having extended therapy for babesiosis with a combination of herbals, supplements, and anti-infectives, antiparasitics. And by the way, we are not an antibiotic factory. We don't put everybody on IV, 24 hours a day, 12 months a year. That is not Jemsek. We don't do that. It doesn't work, for one thing. And we'll get more into the treatment considerations of the lifestyle and the life patterns of the organisms and how we use that to our advantage to target the organism. So first of all, combination therapies and so forth. So we go through all that, but to the point, Babesia, we know takes several months of therapy using several anti-infectives of with different properties, attacking different parts of the organism, hoping that they're synergistic. We're always looking for synergies, just like when I did HIV. The little booger comes back a lot, however, even in people that have done well, especially in people that were, extraordinarily sick at the beginning and did IV therapy. So people would relapse. They would never go back to square one. So it's not a square one issue. No, it's not a square one issue. They'll take 2 steps back and they'll be upset because they were starting to go on that linear pathway or elevated pathway to recovery. So the trajectory was good, but then it got chilled out. Maybe there's another trigger. Maybe COVID happened. But then Babesia reactivates. So that begs the question, did you ever eradicate Babesia? I think in some people we can. But again, our program is all about getting the immune system in charge, so the better that you do, the less that we do. And when Babesia comes back, it is a pain in the you-know-what. And patients say, okay, we have to do 6 months of therapy, which is 10 days a month or 12 days a month. And it's a pain in the butt, and you'll start to see improvement in 3 months, and the vast majority of patients get back to where they were. So what we've been doing, my idea a couple of years ago was, you know what, I am tired and sorry for the patients who relapse, because this is the number one reason, and it can be created by various stressors. For example, they don't have to have another tick bite, or they could. That could be the trigger, and it disrupts or destabilizes their immunologic control, which is growing and trying to become much, much more dominant, but it takes a while. And when they relapse that way, that leads to a cascade of symptoms. Again, they're not nearly as severe as before, but very disappointing because our patients are in a different place. Their life is starting to come to them, and they're starting to feel like themselves, and all of a sudden they take a step back. It's treatable, but so what we've done fairly routinely and with good acceptance, we get some groans, but nobody's really said, no, absolutely, I'm not doing that again. I'm not thinking Mepron, that yellow stuff. I said, yeah, that's really yellow, isn't it? It's really, really yellow. And they say to me, hey, Dr. J, have you ever taken cryptolepis? And I say, that's one I haven't taken. I understand how bad it is. No, thank you. But you know what? It's an amazing little molecule. So we're going to do that again. What we've done is take a stable patient. Somebody's gone through our 13 months of oral therapy, or 13 months of IV and oral therapy combined. It's been on maintenance, and they ring our maintenance bell. They ring our happy bell in our hallway and take photos because they're on maintenance. And the healing process begins in earnest. So 2 to 6 months into that process, I've already told them, we're probably going to retreat you for babesiosis, even though you're feeling well. And here's the reason. We think it's going to cut the relapse rate by 50 to 75%. And you know what? We've been doing a couple of years, and knock on wood, I haven't had anybody come back that's reinforced their treatment with another round of babesia. Here's the rationale. The rationale is that the immune system, while not dramatically improved, is improved. And so now when you go through and treat again, you've got a much more stable patient. Their stressors are less. Their immune system is more able to devote, not only stronger, but able to devote its energies to retreating the babesiosis. And so we do it for 2 cycles or 3 cycles. And we use combinations of atovaquone in some form, the Artemisia group, the cryptolepis group, a MOSA group, a couple of contributory antimicrobials, sometimes coartem, sometimes annula, and so forth and so on. And we're gradually expanding that. We're happy to use other antimalarials, sometimes use pyrimethamine, but we're constantly learning about trying to improve. And that's why it's so sad that the GLA study was dashed, because we would have had some data we never had before, and a marker that would tell us this is the best marker or markers to follow, and maybe we could do things a little better. And it's really a tragedy that wasn't done, but that's water under the bridge. One more thing before I turn it over to dear Rachel, and that is one of our favorite subjects, and that's gallbladder disease. Why does my 10-year-old have gallbladder infection? I'm not kidding you. We've taken gallbladders out of 10-year-olds, I think 8-year-old actually, a couple of mini teenagers, and it's a new phenomenon. It's not in the textbooks. Dr. Trad and I published this as an abstract at SAGES in Las Vegas in September last year. We need to write the manuscript. It'll be groundbreaking. There wasn't the term Lyme in the title. It was accepted by the American Academy of Surgery. And I always thought, it's in the textbook. It's not in the textbooks. I mean, there's an occasional case of cholecystitis. That's inflammation of the gallbladder, sick gallbladder, without stones. So as you know, almost all gallbladder cases have stones. These do not. And they don't show up in the ultrasound or the CT. But we have something tricky that we do. We examine the patient, and we have definite clinical criteria. So does Dr. Trad, bless his heart. So we examine the patient, and we know whether it's in the medial or lateral right upper quadrant, if there's a certain amount of discomfort and it lasts for 5 minutes, when I palpate that area and press firmly, there is a problem there, especially in somebody who's had bloating, referred pain to the back, reflux, and so forth. So it's different in a lot of ways from classic cholecystitis. So here's a disease that's going to go in the textbooks as a new chapter in the textbooks one day. So that's pretty cool. I'm very proud of that. But it is it's a roadblock, and so we suspect that we had send patients for the ultrasound, just jump through the hoops. It's negative or normal. HIDA might even be normal, but if the patient reacts on the table after CCK or the pancreatic enzyme is injected, that's not normal. And so they're a candidate, and we refer them to Dr. Trad and others. And it's interesting because once the surgeon does his laparoscopic colostectomy, he looks in there and says, holy cow, this is a mess. Even in this 15-year-old, there's scar tissue everywhere, there's strands, fiber strands everywhere. The gallbladder's pale, or the gallbladder's inflamed red and blue, and just nasty. And out it comes. And so what you do with that is you reduce an inflammatory mass, which reduces your systemic inflammatory load, And at that point, in most cases, not all cases, at that point, we're able to proceed with therapy once there's a 2-week recovery period. So I'm going to turn it over to Rachel. Those are some of the 25 roadblocks. We can't do them all, but they do exist, and we know about them all, and we're learning all the time. And then Rachel has some questions that came from you, which are very good, and dovetail into another subject. Mm-hmm. Thank you.
Also, most of you know that if you do have gallbladder disease and Dr. Jemsek pokes on you, it's going to hurt. So dovetailing back into the clinical and social obstacles, we got a lot of questions from patients and followers on the Facebook page about focused gynecologic, obstetric, and hormonal issues. Many of our patients know that, Kim, Candace, Dr. Jemsek, Sonia, all the practitioners here, when we see a patient, we are going to review poems. We're going to check in on your pain, your sleep, your other factors, your support person, etc. If you're still struggling, we're going to start looking for some of these outliers or obstacles that are going to get in the way of you getting better or feeling better. And one of those is, hormonal fluctuation. We focus a lot of times on identifying whether there is premenstrual volatility. I was talking to a patient just yesterday, I think, about the fact that as, females, or a lot of our female population, we are up against obstacles just by being the female gender. And what I mean by that is that, we have to deal with puberty, so getting a menstrual cycle, which is a huge disruption to, our inflammatory process, hormones, etc. We then have a monthly menstrual cycle. Some of us go on to have children, which is, its own thing. And then we go through menopause. And all of those different phases, even in a healthy individual, are a burden to the body, right? Good or bad. Then when you are dealing with a patient that has a chronic inflammatory disease such as Lyme, you add these additional inflammatory obstacles, and it causes significant destabilization. So many times we'll ask patients who are, in their fertile stages of life and having menstrual cycles, we ask them the question, are you having symptoms around your period that include some of your baseline Lyme symptoms, just worse, right? So maybe, let's say I'm a Lyme patient that has joint pain and brain fog. Is your joint pain and brain fog worse in your premenstrual state than it is on your other days, right? And also, how many days is that? Dr. Jemsek has always emphasized to me that it's important to see how destabilized they are before their menstrual cycle and for how long. So if it's like 2, 3, 4, 5 days, that's a big chunk of the month for patients to be destabilized just from their menstrual cycle, right? Let alone adding in variables such as antibiotic cycles, their off weeks, attempting to detox, so on and so forth. So that's something that we take into account and take very seriously. We have a lot of our patients work closely with their gynecologists to get on hormone replacement therapy or birth control to help control the hormone fluctuation that then can lead to some of this premenstrual volatility. I'm going to turn it back over briefly to Dr. Jemsek to talk us about some of the pathophysiology that goes into that.
So during the follicular and luteal phase, estrogen is increased, of course, and then it drops down towards the end of the cycle with progesterone coming up. Estrogen and actually HCG are anti-inflammatory. And so this is a good explanation for why some of our more seriously affected women can actually feel better during pregnancy. That's not always the case, but often the case, because they're flooded with estrogen, which then, of course, goes away entirely after delivery. Now, if you look at the hormonal fluctuations and you see that estrogen's dropping and progesterone's rising, what also happens is that arachidonic acid gives rise to prostaglandins, which are pro-inflammatory mediators. And so those prostaglandins may surge, and that's normal, and so the patient feels worse before the cycle and then tends to feel better once they menstruate. what can you do about that? And as Rachel said, it really it depends on how. If it's a day or two, and you can take some naproxen or Advil, which we do allow very cautiously with food. Be careful. They're COX inhibitors, and so there is a COX-2 phenomenon going on with conversion of arachidonic acid to prostaglandin. So, they're appropriate. Fish oil is also appropriate. A quality omega-3 fish oil, maybe a couple grams twice a day or more than you're used to taking, if you can anticipate, and that may ameliorate some of the inflammatory symptoms, because you're not just having flushing and flashes and sweats. You're having your headaches, you're having your fog, you're having your body pain, you're having your sleep disturbance, and so forth. What if it goes on? What's the cutoff? And it's arbitrary, but when I'm very concerned, I think we're all concerned, if our patients are dealing with this and they're incapacitated for 3 days, certainly 5 days, and then we have 10 days. And we cannot get people better if they're incapacitated 10 days out of 28. Because after all, remember, our goal is to reestablish immunologic control through intelligent, progressive use of support medications, herbs, and combination treatments. And if you have 10 days out of 28, it's not happening. So we do not prescribe birth control, but we do recommend the appropriate patient. Not everybody's appropriate or had, and obviously there are issues with birth control use. We talk about continuous birth control. And we work with the obstetrician or the GYN at home. We don't write them, but we do suggest them, and more often than not, they'll comply and go on birth control. The idea is to not ovulate for 90 days or longer. An option is Mirena IUD, which is longer. And at that point, once that's settled and once that's resolved to some extent or manageable, then our patient, everything else equal, is ready to go into our therapy.
And to feed off that as well, a lot of patients that have seen me in the past, this conversation may sound familiar, but a lot of my IV patients, they always say, like, Rachel, why are you trying to kind of constantly add medications or mold or change my picture? And I always tell them, I say, if I could keep you in a little bubble next to me at all times, safe, protected, and without all these other variables, number one, it would make my life a lot easier to treat you, but they would also feel a lot better and be able to just progress with treatment. And that's kind of a similar mindset with what Dr. Jemsek was talking about with the continuous birth control. If we are able to eradicate that menstrual cycle, which is in some of you very volatile, it takes one of those variables away and allows the body and the immune system to focus on what we're trying to get it to focus on, which is treatment and this infection that needs to be taken away. One of you guys' questions that kind of goes into this as well is asking, menopause and Lyme symptoms. Could menopause and treatment make me feel worse? And I think this is a really great question. I think the short answer is yes. We see obstacles with menopause just like we see obstacles with your menstrual cycle. Some of that is quite simply that the hormones that you once had in certain levels to support your system are dwindling or becoming diminished, right? So we see, atrophic vaginitis, things like that, because we're not having enough estrogen, which causes a whole nother slew of issues with, candida or, dysbiosis within the vaginal flora, which is not only wildly uncomfortable for our patients, but confuses, symptoms with other diagnoses that might be going on. We see testosterone going down, progesterone, which can affect sleep, cause you guys to be having night sweats, which confuses us with babesia, and the list goes on. And then if we pair going through menopause, which, as the women in this group of watchers will know, is not necessarily like one day I have menopause and now I'm done with this. No. You get to go through this over a period of months or sometimes, for the unfortunate, over years. And so, if we pair menopause with treatment, it causes many times an exacerbation of those issues. Do you want to add anything to that, to Dr. Jemsek, or I can move on to the next?
Just to point out, we have to take it in context where the patient is in our therapy. So we have, if a patient's 2 years into our therapy or 3 years and on maintenance, that's a whole different story. if I think it's going to be much more confounding influence if patients just starting therapy, and we'll have to work with the GYN in that regard. But if patients full out on therapy, they usually, with a little support, will do just fine. The night sweats that people have, by the way, just let me make a comment. This is so common. Everybody is learning about our nervous system and brain, I know, because you study it at night. I'm sure you have the textbooks open. And the autonomic nervous system is involved in just about everyone, and that causes, defects there cause temperature dysregulation, movement intolerance, blood pressure changes, and inappropriate discharging of the sympathetic system, which causes sweats. Of course, babesia is classic for causing big night sweats. So we get our patients better 2 or 3 years down the road, and now they start sweating again. But in general, they're recovered and doing very well. But now they got the night sweats again. What's going on? I'm starting to get chills. My right arm is cold. My left arm is warm. And I just, sometimes I go out and I'm just hot or I'm cold. And this is a rebooting of the autonomic nervous system. So we have to reassure patients. There's no way they can know. And there's no way they should know this. And we don't forecast this. We have to see them and reassure them, make sure they're not having relapse of babesia, as I mentioned before. So adding menopause on top of that, even in the post-treatment phase and the maintenance phase, can be a little bit confusing, and time will tell.
All right. So this is a question that Dr. Jemsek wanted to take, that one of you sent in. Do Lyme patients typically have hormonal imbalances? I'm on hormone treatment and wondering if I should stop my protocol during this hormone treatment.
Well, if you're with a women's specialist that's doing hormones and there are more and more coming out, no, we don't change anything. We just work with the individual. I'm a big fan of testosterone in the ladies in particular, gentlemen as well. Gentlemen, it's a second tier issue. Women, it's a 1.5 tier issue, but it is important for muscle integrity, for libido, for actually fermentation. So when patients are getting creams and good combination estrogen and estradiol and progesterone, I like it when there's some testosterone in there. I'm not a big fan of pellets because they're so irregular, but some women do that as well. But we like to restore the testosterone for women, and we'll do that actually. But as far as the female hormones, the creams, the pills, the suppositories, etc., we don't get involved in that.
And I think the providers here, our preference many times is the creams or the compounded creams because it's able to be so specific to the patient.
And flexible.
And flexible, yeah. So, the pellets are, an implanted pellet that is not flexible and also just a continuous exposure of medication, whereas a compounded cream, you're looking at a patient getting hormone levels and then creating a cream that's a perfect combination of hormones for them. It is sometimes hard to find practitioners that are, well-versed in doing that, but, there are more and more of them. So the next question that we got from you guys was, do you find that PCOS and or endometriosis are common with patients? And this actually ties into one of the outliers or roadblocks that Dr. Jemsek and I have discussed before and that Dr. Jemsek has not yet published, but will. Severe endometriosis is something that we see more frequently than we'd like to. It is a complicated issue because it is difficult to diagnose. As many of you know, endometriosis is usually only able to be definitively diagnosed when it is seen, to the naked eye, which has to be done via surgery. So usually identified with laparoscopic exploratory surgery. We know that endometriosis causes heightened inflammation and pain, which is another variable that affects their treatment. Treatment of endometriosis ends up being sometimes a pretty invasive surgery, which also causes patients to have to hold or pause treatment for sometimes weeks or months to be able to recover from this and allow themselves to get stable again before reintroducing antibiotics. PCOS, I don't think that we touch on that as much. I think it's a secondary diagnosis, but the endometriosis is definitely a factor. Do you want to add anything to that, Dr. Jemsek?
Yeah, I'd like to. I just want to go back to the hormonal change in women, and there's no question that I think primarily because of adrenal insufficiency, they're messaging hormones from the adrenal, from the pituitary. The anterior pituitary has 6 hormones, including LH and FSH. There is a posterior pituitary that has diabetes, that has vasopressin, and prolactin, not sure. Anyway, the love hormone. But at any rate, the pituitary and hypothalamus get whacked because it's a high-intensity region, very vascular. These swarm of infections love the lower brain, the limbic brain, where the white matter is, and they love the brainstem, and they love the cervical roots. And so we see all kinds, talk about endocrine, we see all kinds of hypothalamic disorders, and so our males may have hypogonadism, or may have low testosterone even if they're young, and our females, of course, have all sorts of hormonal issues. Beyond that, their cycles become irregular, and I've had numerous females during their chronic illness, ongoing, incessant, never-stopping illness. I've had numerous ladies who had amenorrhea. They stopped having cycles for 6 months, a year, or year and a half, or 2. And it's a very consistent finding, if they're premenopausal, of course, a very consistent finding that once we get them better and the pituitary heals a little bit and starts kicking in, the ladies start having menstruation. And they're so thankful to me for it. They just, they're gushing with thanks that they're menstruating again. So I just say, you're welcome, and go, move on. Now I'm sorry about that. Endometriosis, I think, is a new field. I spoke with a very nice young gynecologist who just moved to the area and did special training in endometriosis. There are endometriosis centers around the country. They're not and this young lady, or young doctor, I should say, said, you know what, it's an expanding disease and there's not enough doctors. And I said, because I asked her, I said, is that the case? Just, we think this is awful. We know how long the surgery takes, but I know these implants are infected. In fact, we had a PCR. I don't really sample tissue very much, but years ago I had a PCR positive from a myoma from the uterus. So if it can do that, I'm pretty sure the endometrial implants are infected. I just know it because that's what this disease does. And I don't know if it's just a spirochete or other pathogens. But this is a tedious surgery, but the rewards are very great, and this is another roadblock. So, and of course, as Rachel said, we can't diagnose it by imaging. You just can't diagnose it. You have to go in and take a look. You can't diagnose this by exam. You can be suspicious, but having this extensive surgery is life-altering for a number of women, and I think we're going to see more and more of this. And it's another ugly and unfortunate manifestation of LBC.
Another point I wanted to make, too, that Dr. Jemsek just hit on was, reinforcing that imaging is not useful for endometriosis in regards to a diagnosis. And, what I find interesting is that there's actually a lot of roadblock diagnoses for Lyme patients that are not able to be diagnosed via image or are very complicated to be diagnosed via imaging. One example is chronic calculus cholecystitis, which Dr. Jemsek, discussed before. A lot of times, it's not until Dr. Trad or other surgeons, get in and identify how scarred down and inflamed the gallbladder is that they realize that it's a problem and it needed to come out, where the imaging may not have been profound. We see this with other areas that we'll touch on a little bit later today, or the different Facebook Live, such as, chronic appendicitis, and things like that. But one thing I wanted to move to just briefly before we get on to the next question, one of you posted a question about What about young kids getting hit by the prepubescent years, dealing with this? I think this is a really good question, and pertains to what we're talking about right now. And I won't do this question justice like Candace Willett would, who's our pediatric nurse practitioner, but this definitely affects our prepubescent patients. When we look at our pediatric and adolescent patient group, we have general developmental milestones that we can track. And what's interesting is that when they have Lyme disease, those developmental milestones are altered, right? Now, we also know that there are milestones or expected symptoms for, pediatric patients at certain ages. And it is definitely something that Candace and also Kim and I, if we see some of these younger patients, we look for when they are in that prepubescent phase. Say that word 5 times fast. Because we see this heightened inflammation, and that's going to affect these kids in regards to their concentration in school, as well as their mood, get that moodiness a little earlier, and affects both our guys and gals in regards to the pre-initiation of their menstrual cycle, or just our guys getting a jump in their testosterone. So it's definitely something that we look for and have to stabilize for, with those patients. The next question that you guys asked was, have you noticed if Lyme patients struggle with infertility or getting pregnant? And this is a great question. Just briefly before I turn over Dr. Jemsek's thoughts, I do think that Lyme patients struggle with infertility. We do have tons of our patients that have gone on to have gorgeous babies. We love babies in this clinic. But infertility is definitely an issue, and it's sometimes what brings patients here. So I've had a number of patients that have been relatively asymptomatic, save for the fact that they can't get pregnant. There's some pathophysiology aspects that I will leave it to the big man to discuss, but we know that there are genetic factors that are linked with Lyme disease that cause early spontaneous miscarriages. And we also see that because of the inflammatory process, the hormones are unable to allow for a normal, healthy pregnancy. Dr. Jemsek, your thoughts?
My thoughts? You pretty much
pregnancy?
said it all. I mean, yeah, it's tragic because, again, go back to the pituitary. If it's not working, you're not going to ovulate. And on top of that, I think there's pervasive infection of the uterus and on any other organ in the pelvis and anywhere else in the body, and the bladder, we can talk about it another day, but it not necessarily the spirochete, but probably the spirochete, but also a host of other co-infections. And we would like to do a very simple study, so simple, just an observational study, which looks at our patient population coming in and get the end value that we need. How many ladies have had miscarriages? And compare that to the general population. And my feeling is like with a lot of other inflammatory conditions affecting the gut and bladder and anything else, the incidence is going to be much, much higher. So many of our patients have struggled to have a child. They want to have a child. And we should probably talk about what we do with pregnancy. Yeah. Okay, that's
our next question, too.
That's our next question. So the next question is...
Next question is what is your success with moms who have babies born with Lyme, or patients that have Lyme that go on to have babies, and what does that entail in regards to treatment for them during pregnancy, and also just our success with it?
Right. Okay. So our preference is that our patients are treated and 2 or 3 years out on maintenance and healing. That's the wish. That's not the real world. So in the real world, we have ladies in their late 30s or early 40s who have one child, one another, or who are without child. So, but there has to be some success with treatment. There has to be some. And there has to be some stability. And of course, a lot of the meds are taken away with pregnancy. But here's what we have over my career. to guess, and I wish I had records, but I don't. But I do have in my head that we've seen 240 ladies who became pregnant. Many, maybe in the year just following their treatment, which is a little early in my regard, but maybe they're 40 years old, so we say, okay. I have one patient that comes to mind who came to my office comatose, a young lady from Virginia, and she didn't remember me for 6 months, and now she's alive, alert, happy, productive, and has 3 gorgeous children, and I get the postcards. And she named one of her baby girl, her second one, Josephine, because I was kidding with her. I always say, because the patient will ask me, well, Dr. Jemsek, I think I did this before. Can I have a baby? And so I'm like Solomon there. Well, you have a baby. You may conceive, my child, but a male child must be named Joseph, and a female child must be named Josephine. Well, this patient took me seriously, and so Josephine is named after. But it's a wonderful story, and the pictures are, storybook. And anyway, 240 ladies, 200 we do PCR analysis of umbilical blood for the spirochete to see if the spirochete is there. If it's not there, does that mean the spirochete didn't get into the womb? No, because the spirochete can get anywhere, but at least they're not infested and haven't caused major tissue damage. So we've had 4 infected out of 200. So that's 2%. And I have had one for a very long time. And of course, we work with the OB. We send letters to the OB, say, here's what we're doing. We're going to put the patient on something like fetus-friendly drugs is what we say. Drugs that by convention seem to be safe for pregnancy, because nobody does double-blind trials on new drugs in pregnancy, right? So fetus-friendly drugs would be in the amoxicillin class, perhaps the cephalosporin class, drugs like cefuroxime or Ceftin, Ceftonir or Omnicef, etc., plus Zithromax, and that's pretty much it. And then it's totally, the OB is the captain of the ship. Our patients are allowed to take whatever the OB says, and that's it. That's final. But that's our experience. And so our patients will have a visit, maybe a phone chat during pregnancy, and we'll see them after the pregnancy, bring the baby, and have a nice big hug, and everybody's happy.
And I think what's important to know too, in regards to patients that go on to have successful pregnancies and the outcomes therein, all these women are in different phases of treatment or post-treatment, right? And that affects, the PCR or the, cord blood results. So, I would say that some patients are able to tolerate treatment through pregnancy, reducing, their risk of transfer. Some patients are in the middle of intense therapy themselves when they find out they're pregnant and then have to go on to, deliver. So all these variables affect the outcome of how healthy that baby is. But I would say that in general, our success rate has been very good, with having healthy JSC babies.
We have some marvelous pictures.
We do have some marvelous pictures. Keep them coming, because I have them posted all over my office from our JSC kiddos or success stories, and they're very cute. So we wanted to circle back towards the end of this Facebook Live with kind of addressing COVID and the roadblock that poses to treatment. So I'm going to read this final question and let Dr. Jemsek take this. And, before I do, I just want to thank you guys for being patient with us, for the technical delay, and, sending in fantastic questions during this live as well as prior to. It's really, a privilege for us. So this final question is, I'm about to start treatment but got infected by COVID and still have some remaining symptoms. Will this affect the start of my treatment? Dr. Jemsek.
Thank you. So, conceptually, when we talk about this illness, we talk about us having commensal organisms, so there's some immunologic disruption, whether it's a new infection, a trauma of any kind, a series of stressors of any kind, and the patient losing immunologic control of these infections. And there goes the spirochete, and it's abated by Babesia, Bartonella, Ehrlichia, Anaplasmosis, Chlamydia, Mycoplasma, Proteomyxoma, leaky gut, tons of biofilm, candida, just on and on and on, all sorts of neurologic symptoms. And affecting the brain in no other disease has done, so we're less able to compensate. We're less able to do our exercises as we get more fatigued and inflamed. We're less able to have quality sleep and so forth. So I look at COVID as a master trigger. So if you are compensated but asymptomatic, whether or not you think you've ever had Lyme borreliosis, here comes COVID, and guess what? You're at risk for having longer-term symptoms. It may cause clinical expression of a constellation of symptoms in the neuropsychiatric and neurocognitive areas, general fatigue, chronic inflammation. So COVID introduces an M protein, and so does the vaccine, and there's some evidence now that it may persist. And COVID itself populates the same neural pathways and in the brain itself that LBC has done. So here we are with tissues trying to recover, and here comes COVID, dysregulating the immune system, causing all kinds of chaos, more inflammation, and deteriorating health. So COVID can devastate people, but in the usual case, it's bad, but it's not devastating. But it does. If someone's halfway through therapy and they get COVID, unfortunately, we're going to treat that COVID, but it sends them sideways for a while, and it takes 4 to 6 months to recover to get back to where you were. And that's our pattern, and we feel it occurs with natural infection and maybe less often with the vaccine, but definitely the vaccine has caused some significant adverse effects. I wish all of them were reported. I can't say too much more because the COVID paddy wagon may turn around the corner with Officer Fauci in high boots and with a whip. So I just can't say too much more. Everything's so politicized, including the COVID pandemic, and of course Lyme. Everybody's suffering for 2-3 decades with the politicization of this awful illness. And again, our mission is to try to promote education. I try not to be too political. I guess I was a little bit there, but I apologize, Mr. Fauci. And hope you're better from your COVID. But our mission is to help people who can't get to us or can't get to qualified providers because of access to care, money, travel, and so forth. Our heart goes out to those people, knowing that there are millions out there in the community and around the world.
So thanks so much, guys. This concludes the 20th Facebook Live, and we look forward to getting back with you next month, hopefully.
We will get back. It'll be number 21.